Hello, my name is Dr. Terry Trentman. I'm an anesthesiologist at Mayo Clinic in Arizona, and I'd like to share with you some information about anesthesia and also preoperative evaluation for prostate surgery. I'll begin with preoperative evaluation. The purpose of a pre-op eval is to optimize the patient before surgery. We want to address any issues, medically speaking, that could lead to adverse events around the time of surgery. And we also want to carry out a preoperative evaluation so that the patient's hospital course is as short as possible. We don't want them to be stuck in the hospital longer than absolutely necessary. So I'll talk a little bit stepwise regarding the pre-op evaluation. And after that, we'll talk about different types of anesthesia for prostate surgery. Now, in our practice, we have a formal pre-op clinic, a place that patients are sent to be evaluated before surgery. Other practices don't have this. The surgeon may perform the pre-op evaluation themselves, or they might send the patient to an internist or to a family practice doctor to be cleared for surgery. When a patient goes to our pre-op clinic, we ask them a number of questions about different body systems, such as the heart and lungs, the nervous system, to check their readiness for surgery. And so I'll walk through some of these in a stepwise fashion. Logically, why don't we start at the top with the brain and the nervous system. In the pre-op clinic, we ask our patients if they have any history of neurologic disease. Have they had a stroke? Have they had a mini stroke or a TIA, as it's called? Do they have any kind of neuropathy, which means that the nerves in some part of the body don't work normally? If so, we'll ask for details around those conditions and treatments that may have been given to the patient. Moving down, another area of interest to us is the head and neck. During a general anesthetic, after the patient is asleep, a breathing tube is placed in the mouth and into the windpipe. They breathe through this tube during the surgery. So both the anesthesiologist and the pre-op provider will be very interested in the patient's head and neck. For instance, have they had neck surgery, or do they have neck arthritis, something that would decrease the range of motion of their head and neck? We're also interested to know if they have conditions like TMJ, or have they had cancer or radiation treatment to their neck. Again, looking for problems that would decrease their ability to open their mouth or to move their neck around. Moving on, another important area for us is, of course, the heart. And in the pre-op clinic, we would ask a lot of questions around heart function. We want to know if the patient has ever had a heart attack. Have they ever had a heart procedure for coronary artery disease, such as stent placement in the coronary artery? Have they had heart failure, heart valve problems, or heart rhythm problems, such as atrial fibrillation? During this part of the examination, the pre-op provider will ask the patient about their exercise tolerance. What can they do as far as exercise? Can they go for a walk? Do they work out? Can they walk up a flight of stairs without stopping? Can they carry 20 pounds, 20 feet, for instance? These questions are designed, again, to assess their heart function and what kind of shape they're in. If a patient has certain conditions like atrial fibrillation or coronary stents, they may have been given blood thinners. Blood thinners are also very important to us around the time of surgery. If the patient is on blood thinners, the pre-op provider will coordinate with them and instruct them how to take those medications before and after surgery. Typically, we don't want the patient to come to surgery on blood thinners, but we never want our patients to stop their blood thinners without receiving instructions from their physician. As part of the cardiac evaluation, we may order further testing, for instance, an echocardiogram or an EKG. Occasionally, we'll refer a patient to the cardiologist for further evaluation. If the patient has had an outside evaluation, for instance, an echocardiogram at another medical center, we'll ask for those records and we'll work with them so that those records are available the day of their visit. Moving on, let's talk a little bit about lung disease. In the pre-op setting, we're very interested in the patient's pulmonary status, how their lungs work, and the patient will be asked about a history of smoking. Are they a current smoker? If they've stopped smoking, when did they stop? How much did they smoke before? And do they have any conditions like emphysema, COPD, bronchitis, or asthma? And what kind of medicines they take for their lungs, such as inhalers. Smoking is an important issue around the time of surgery and in general for health. We encourage our patients to stop smoking before surgery, and that's actually a very good time for patients to reassess their health and make a decision to stop smoking. If the patient needs help with that, the pre-op provider can refer them to resources to assist with that. A related issue is sleep apnea. Sleep apnea is characterized by snoring and periods during sleep when the individual actually stops breathing completely. Often, a bed partner will tell them that they have this problem. They may not realize it themselves, and there are many patients who have sleep apnea and don't realize it. So the pre-op provider will ask the patient about sleep apnea. If they have been diagnosed and have a CPAP machine, they'll be asked to bring that with them to the hospital for their surgery. We may ask the respiratory therapist to see them after surgery. And in some instances, we'll refer a patient to our sleep medicine clinic so that they can undergo an evaluation there. Let's keep going and talk about some other medical conditions of interest. Another area is renal disease and liver disease. Certainly these organs are important for good surgical outcomes, and we'll ask if the patient has any kind of problems there. Often laboratory work is obtained before surgery to assess both renal and liver function. The final medical condition I'll mention is endocrine conditions. Thyroid disease is of interest to us, and of course diabetes. We'll ask the patient if they have a history of diabetes. Are they being treated with diet only, or with medications by mouth, or insulin injections, or other medications? We'll want to know what their blood sugar is and their hemoglobin A1C, which is a measure of how well their blood sugar has been controlled in the previous months. The patient will be given instructions as far as how to manage their diabetes medicines around the time of surgery, and in some cases we'll refer the patient to an endocrinologist for more advice, particularly if we decide that the patient's diabetes is poorly controlled. It's important to have good diabetic control before surgery because of the risk of infection afterwards. Finally, as part of the preoperative evaluation, the patient's allergies will be reviewed, all of their medications will be reviewed, and the patient will be given instructions about fasting so that they're clear about when to stop eating and drinking before surgery. As a rule of thumb in our practice, we ask our patients not to eat anything solid after midnight. We tell them that they can continue clear liquids up to 2 hours before their arrival time for surgery. Clear liquids are anything you can see through. Water, apple juice, black coffee with nothing in it are acceptable to drink up to 2 hours before the planned arrival time in the hospital. So with that, let's move on and talk a little bit about anesthesia options for prostate surgery. At a high level, anesthesia can consist of general anesthesia, where the patient is completely unconscious, where we place some kind of breathing device in the mouth to help them breathe during surgery. Another option is a regional anesthetic, such as a spinal anesthetic. In a regional anesthetic, we numb a certain part of the body for the procedure, and then during the procedure itself, the patient is sedated, but not technically under general anesthesia. Another type of anesthesia is sedation, also called conscious sedation. A common procedure where we use conscious sedation is colonoscopy. The patients are given medications through the vein, but they're breathing well on their own. They're sedated. Many patients who receive conscious sedation believe that they had general anesthesia because they don't remember anything from the procedure, which is good. That's what we want. But technically, it doesn't meet the definition of general anesthesia as I've described. For prostate surgery, all of those options are possible. It depends on the type of surgery, the length of the surgery, and a conversation between the patient, the anesthesiologist, and their surgeon regarding the needs of that person in that situation. For instance, a prostate biopsy, which is generally a minor procedure, can be done under conscious sedation, medicines just through the vein, with the surgeon numbing the area where they're performing the procedure. A prostate surgery such as a transurethral resection of the prostate or the TURP procedure can be done under a regional anesthesia like a spinal anesthetic. A spinal anesthetic is performed by injecting a small amount of Novocaine in the spinal canal to numb the body from about the belly button down. Again, during the procedure, the patient is typically sedated. The spinal anesthetic provides excellent pain relief and a nice recovery for the patient. It has a small risk of a headache afterwards, but the older a patient is, the lower their risk is for a headache. The spinal only lasts for anywhere from 90 minutes to 3 hours, depending on the medication used, so it has to be planned for a procedure that would be completed in that time frame. And sometimes we can't perform a spinal anesthetic because the patient has arthritis in their spine or other issues, and so we, in that case, need to perform a general anesthetic. A full general anesthetic is always a backup plan for a spinal anesthetic if it's not successful. Finally, I'll mention general anesthesia. Again, general anesthesia is when the patient is completely unconscious and we're assisting their breathing during the procedure. For a major prostate surgery, such as a robotic prostatectomy, the patient would be under general anesthesia. This type of surgery would be too lengthy and would not fit a regional anesthetic like a spinal. During a robotic prostatectomy, the abdomen is filled with gases, and the patient is often tipped downward, sort of standing on their head to some degree. Again, this requires a general anesthetic where we can protect their airway to be safe. I hope this discussion has been helpful for you in regards to pre-op evaluation and different types of anesthesia for prostate surgery. Thank you.